So thank you very much, and thank you for inviting me to this very nice symposium. It's the second year, was it? Yeah, second time?
Yeah.
Yeah. So, single-shot devices. Yeah. First, we have to define what we mean with single-shot devices. I think it's one-shot tool. One transvenous ablation application should result in a contiguous lesion for pulmonary vein isolation without the concept of sort of point-by-point lesion. So what tools do we have for that kind of procedure? We have cryo balloon, creating contiguous lesions. We have a hot balloon, also creating contiguous lesions. The X is displayed there. We have a laser balloon that results in point-by-point. A basket catheter with an RF device inside it. It's a point-by-point. A circular RF ablation catheter, the PVAC, is also point-by-point. The semicircular RF ablation catheter, the ANMARC, is also point-by-point. So I think the ones that we have presently is the cryo balloon and the hot radiofrequency balloon, whilst the other techniques are actually point-by-point lesions, although they mimic a sort of one-shot device. So we have only one from the with the cryo technique. So I think we should start off with this slide showing that 1980 Cox demonstrated very nicely that by isolating the left atrium, you could have sinus rhythm in the rest of the heart. So my interpretation is actually that this reflects the isolation of the pulmonary veins. The next great scientific event was Heisager's publication of the transvenous pulmonary vein circulation. Also I think Paponi should have some credit for publishing the result from the wide circumferential ablation lesions. Yeah. So let's see, what were the results of this pulmonary vein isolation? These are the first 11 randomized clinical trials comparing AF ablation versus antiarrhythmic drugs. And I show it to you just to demonstrate how variable the success rates were. And the success rates were defined as the patient were AF-free, free from atrial fibrillation with a duration longer than 30 seconds at 1 year follow-up. But there is a quite large variation, irrespective of whether it was paroxysmal or persistent. We have only 3 persistent trials. Then I would like you to focus on the light blue bars, because these are the control groups. These are the patients that had antiarrhythmic drug medication, at least 1 or usually 2 drugs. And it came to my surprise looking into this that it's quite a variable results, even though it's practically the same kind of drugs. You can understand that the ablation procedures have different results because of skill and different techniques. But for the antiarrhythmic drugs, it just reflects that we are dealing with quite different patient populations. And we can see here we have the meta-analysis of cohorts and also randomized trials showing that we have a lower success rate with persistent AF as compared to the paroxysmal AF, and also showing that we have a higher success rate if we repeat the procedures. Finally, this shows the same results, poor results, if only a single ablation is performed, and even poorer results if this group of patients with long-standing persistent atrial fibrillation. And this is a 5-year follow-up, so we have a decline in success rate with time, despite the addition of other kinds of ablation techniques added to the PV isolation. So the recommendations from our guidelines, as shown before from 2012, was actually the PV isolation is the standardized cornerstone of treatment, and if you have long-standing persistent AF, you can go for linear lesions or complex fractionated electrograms. But I don't see that we had that kind of evidence at that time to be able to come up with such a recommendation, actually. So I think that we can interpret that strategies with VACA, antrum isolation, complex fractionated electrograms, linear lesions, CAFE, and even rotormodulation as a kind of see what happens strategy without knowing why we are doing it or what is the rationale behind that kind of approach. So far, PV isolation was still the best. This is exemplified by this study showing the result of CAFE ablation added up to PVI isolation. They compared it and showed that by adding CAFE to PVI, you had a better success rate for the persistent AF only, not any difference for the paroxysmal AF. And why was that? Was it because you added and had a more extensive PVI, or was it because of CAFE itself was effective? We don't know the answer to that question. This is a similar paper showing the same results with regard to adding lines to pulmonary vein isolation, a roof line and an isthmus line. And as we can see, there were improved results only for the patients with persistent AF, no difference for the patients with paroxysmal AF. And why? Is it because you reached more extensive PVI, or is it because the lines itself were effective? And they were also, of course, not randomized after a complete PV isolation was achieved. So no conclusions could be made from these trials. Again, I think we've touched upon this STAR AF2 trial several times today. Just to repeat that, of course, if you randomize into 3 groups, one group with PVI, the other ones adding 2 lesions, you cannot make any conclusions unless you can be sure that you from the start have a complete PV isolation, because you don't know what the effect of the PV isolation is actually. And this study, as you know, showed no difference in outcome. And the same was true also for this study I showed you earlier in my presentation. Different kinds of combination of treatment added to the PVI, no difference in outcome, and lots of reconductions in the PV. So before exploring alternative ablation techniques to PVI, I think we should also focus on why AF recurs after pulmonary vein isolation. I think that's an important question. And we have seen that the main reason is actually reconduction. Veins reconduct, and this is beautifully shown in this study looking into patients who's undergoing the 3rd AF ablation procedure, and they collect the data from 169 patients, and in 92% they found reconnected pulmonary veins, and in only 8% were all PVs isolated. And this is another study showing the same thing. After several AF ablations, there were 6% of patients in whom the PVs were all isolated and the patients still had AF. So, transmurable durable PVI lesions is not easy to achieve with the tools that we have used so far, point-by-point lesion, unless a pulmonary vein isolation is performed by a single-shot tool, creating a contiguous lesion like the cryoballoon. So if we look into these results with the new generation, the 2nd generation cryoballoon, we can see that the results are better, the blue line. It's significantly improved as compared with the old cryoballoon, the red line. And we also see, as for the use of the radiofrequency energy, that we have better results for the paroxysmal AF patient as compared with the persistent AF patients. And this has also been shown in meta-analysis that we have better results with paroxysmal than persistent, and better if we repeat the procedures. And in this meta-analysis, cryo was actually superior to RF in this non-randomized trial. And if we go to the fire and ice study, we can again see that if we look into the cryoballoon advance, it was superior to the RF technique. So one-shot tool, I think, is superior, and I think that is related to the fact that it gives you contiguous lesions. And I think this is one of the studies that support that concept, that you have less gaps, less number of gaps in patients who actually recur and have reconnection. They looked at the number of gaps in the cryo group as compared to the RF group among the patients who actually had reconduction. And when you compare trials, is of course difficult for many reasons. First, you have different patient populations. You will have to define them. I think one other crucial question is, how do you monitor the patients? How can you compare studies unless you monitor the same way? The more you monitor, the more you see. So this is from the trial of Boto, and as you recall, it shows that it's only with the implantable device that you actually detect 100% of the AF episodes. So to conclude, I think there is a lot of studies to be done. It's my belief that pulmonary vein isolation is a key ablation technique, and that you can improve the AF situation for 90 to 95% of the cases. Randomized trials are needed to answer why gaps are so frequent. Why are there more gaps in patients with persistent atrial fibrillation? How can we improve the technique for cryoballoon? Shouldn't we focus more on anatomy, the lesion size transmurality? How can we appreciate while doing the ablation if we have a transmural lesion? Can we tailor the balloon size or the balloon shape to the PVOs? Some os are oval. We also need new randomized trials to explore the value of these additional techniques like cafe ablation, linear ablation, once a chronic PVI is achieved. So there are a lot of studies needed to be done. I think also we have to explore on endpoints, not only look at freedom from atrial fibrillation, which is actually not the indication for the treatment. We should also evaluate quality of life and symptoms in conjunction with a rhythm. Because what if the patient becomes totally asymptomatic after a procedure but still has AF? Is that unsuccessful? I think it's a very successful treatment, because the reason for the patient to undergo the treatment was actually to improve quality of life. So thank you.
Okay, thank you very much.